Hi everybody, welcome back to Izzy Medicine, where the only thing more regular than AFib is my sense of humor. Yes, I'm still making nerdy cardiology jokes. Anywho's, this is part 2 of our EKG interpretation series. In part 1, we tackled the basics, how to read an EKG graph, how to calculate rate, how to spot narrow complex tachycardias, including all the messy atrial stuff like AFib and multifocal atrial tachycardia. In the second half of our series, we're picking right up where we left off, wide complex rhythms. Yay! These are high-stakes arrhythmias that can cause hemodynamic collapse, and this is where reading an EKG can literally become a life-saving skill. So let's jump into it. Now that we've walked through narrow rhythms, let's move into wide complex world, where the QRS duration is greater than 0.12 seconds or more than 3 small boxes. That tells us that the electrical impulse is either traveling through the ventricles abnormally or it's starting in the ventricles altogether. And once again, the question we ask first is it regular or is it irregular? So let's start with the regular ones. Ventricular tachycardia, V-tach. This one is one of those rhythms that always grabs your attention because it's fast, wide, and potentially deadly. In monomorphic V-tach, every QRS looks the same, and by the same, I mean they're wide, ugly, and bizarre looking. The signal is coming from one rogue spot in the ventricles, and it fires at around 120 to 250 beats per minute. There are no P waves in the front. But here's the kicker, and no pun intended, the rhythm itself is regular. It may be wrong, but it's organized. Some patients in V-tach are talking to you, others are completely unconscious. But the thing is that they can switch between those two states very, very quickly. So if the patient is stable, you might reach for an antiarrhythmic, but if they're unstable, for example, hypotensive, altered, or pulseless, you cardiovert or defibrillate, no time to wait. And sometimes they keep going into V-tach. What do? That's when we start thinking about ICDs or implantable cardioverter defibrillators. Now, let's talk about V-tach and give it a twist. Literally. I know, the jokes continue. Torsades de pointes is a special kind of polymorphic V-tach. This is where the QRS complex actually appears to spiral around the baseline. It's like a sine wave that's lost its balance, or kind of like a shiny candy that's twisted on both sides. I'm gonna include a picture here so you know what I'm talking about, but that's what it reminds me of. But this rhythm doesn't show up out of nowhere. It begins with a prolonged QT interval. So let's take a second to explain and understand why and how that matters. The QT interval represents how long it takes the ventricles to depolarize and then repolarize. So basically, contract, relax, and get ready for another contraction at the T wave. And if repolarization takes too long, that relaxation and getting ready phase, some ventricular cells are ready to fire again. They're ready to contract again before others are finished recharging. So what happens that uneven timing creates a perfect setup for early after depolarization. So like little electrical hiccups that can spark a runaway rhythm. And when one of those early beats lands right on the tail of a T wave, that's when the dreaded R on T phenomenon that we see here, that's what can launch a patient into torsades. So what causes a prolonged QT? Who the hell knows? No, I'm just joking. Think A, B, C, D, E. So A for antiarrhythmics. So class 1A like quinidine or procainamide. Class 3 like amiodarone or sotalol. B for antibiotics, and especially macrolides like erythromycin, clarithromycin, fluoroquinolones also. C for antipsychotics or psychotics with a P. Haloperidol, risperidone, these are big offenders. D for antidepressants, so tricyclic antidepressants or SSRIs, especially citalopram, can prolong the QT interval. E for antiemetics, things like Zofran and droperidol that we often use for nausea and vomiting. And also electrolyte abnormalities, low magnesium, low potassium, and low calcium. Sometimes when electrolytes are off, especially magnesium, the heart gets twitchy and repolarization slows down. So any of these can stretch the QT. If you combine a few, for example, if you have a patient that is on an antidepressant like citalopram, also has an arrhythmia and is taking amiodarone, recently got a bronchitis or pneumonia and is on an antibiotic and also has hypertension and is using a thiazide diuretic that's causing their potassium to be low, here you have a recipe for disaster. And if you throw in an underlying heart condition, then we have a party. So when torsades hits, our first move is IV magnesium sulfate, even if the magnesium level is normal. After we've calmed that down, we fix the underlying cause. We replete potassium or we stop the QT prolonging medication, because if we don't treat it, it can devolve into this beauty: ventricular fibrillation. Ventricular fibrillation, VFib, is full-blown electrical anarchy. There are no organized depolarizations, no QRS complexes, no P waves, no cardiac output. What happens here is the ventricles are just twitching chaotically. It looks like scribbles, random course, completely uncoordinated. And this is cardiac arrest. There's no pulse, no blood pressure, no perfusion. The only treatment is immediate defibrillation, plus CPR, plus epinephrine, and whatever caused it needs to be fixed yesterday. Sometimes, unfortunately, patients go from V-tach straight into VFib. Sometimes they show up in VFib out of the blue. But once you've seen it, you'll never forget what it looks like. And once you've treated it, you'll never forget how fast you have to act to treat it. Alrighty, friends. Now, let's slow things down. Literally. Brady arrhythmias. If the heart drops below 60 beats per minute, we've learned that we're in bradycardia territory. If the heart rhythm is irregular, or the communication between the atria and the ventricles is off, you may be looking at some kind of AV block. So let's walk through them in order to understand them. First degree AV block. This one is simple. Everything is normal. We have P waves before every QRS. Spacing is consistent, except the PR interval is just too long. It's greater than 0.2 seconds or more than 5 small boxes. But here's the thing. Every impulse still gets through. There's no dropped beat. It's just a delay through the AV node. With first degree AV block, we don't usually treat this. It's often found incidentally, and the patient is usually fine. But it may be our first hint that the conduction system might be a little sluggish, so we've got to pay attention to these patients anyway. Okay, second degree AV block, or Mobitz type 1. Here, the AV node gets progressively more tired. The PR interval gets longer and longer until poof, one beat doesn't make it through. A QRS drops, and then the cycle resets. So what you'll see is a P wave with no QRS after it, and that's the dropped beat. But before that, what you'll see is the PR interval stretching out slowly like it's losing steam. It takes a little bit long, a little bit longer, and a little bit longer, and then a drop beat. This one is usually also benign, especially if the ventricular rate stays adequate. But if it becomes symptomatic or the drop beats become more frequent, we might need to think about intervening. Second degree AV block, Mobitz type 2. Now this one's a little trickier and more dangerous. Unlike Mobitz type 1, the PR interval is consistent until suddenly a QRS disappears. There's no warning, just a P wave and then silence. This is a block below the AV node, usually in the His-Purkinje system, and it's unpredictable, and that's what makes it kind of scary. Mobitz 2 can progress into complete heart block, so it often needs a pacemaker. If you see this in EKG, you're calling cardiology. If you are cardiology, you're doing cardiology. I'm not cardiology, so I call people. All right, and now to our beautiful complete heart block. Third degree AV block. And this is where full breakup happens. In complete heart block, the atria and the ventricles have stopped talking to each other. They just don't like each other anymore. The P waves are marching out on their own pace, and the QRS complexes are doing their own thing. But there's no relationship between the two. The signal is completely lost. Atrial impulses aren't making it through the AV node at all, and the ventricles are being paced by an escape rhythm, usually a slow, sometimes wide QRS complexes if the origin is low in the conduction system. This is a medical emergency. The patient often has profound bradycardia, hypotension, maybe fainting or altered, and we can start with transcutaneous pacing before we get them a permanent pacemaker. Alrighty, now that we've tackled rhythms, the fast, the slow, and the blocked, let's zoom out and look at how electricity flows across the heart in 3 big picture ways. Where the current is heading, that's axis. How efficiently it's getting there, that's bundle branch blocks. and what the ST segment is telling us in between those big waves. Let's start with axis deviation, which is basically like reading a compass made of electricity. When we talk about axis on EKG, we're referring to the overall direction of ventricular depolarization, or in other words, the path that the electrical signal takes as it spreads across the ventricles. Now, here's the key. We figured that out by looking at the QRS complex because that's the part of the EKG that represents ventricular depolarization. And here's how to read it. If the QRS complex is mostly pointing up in a lead, that means the electrical current is moving towards that lead, and we call that positive. If the QRS is mostly pointing down, the current is moving away, and that's negative. To estimate axis, we use two specific leads. Lead 1, which views the heart from the left side of the chest, and lead AVF, which looks from the feet straight up. So kind of like a crisscross. These leads are perpendicular to each other, so they help us track the vector of electrical flow. Now, let's walk through the possibilities. If both lead 1 and AVF are positive, or the QRS is pointing upwards, that means the electrical signal is moving downward and to the left, just as it should, and that's normal axis. So no worries there. Normal, good to go. If lead 1 is positive, where the QRS is pointing upwards, but AVF is negative, where the QRS is pointing downwards, now the current is drifting more upward and leftward. That's called left axis deviation, and it often shows up when the left ventricle is enlarged, like left ventricular hypertrophy, or there's a left bundle branch block, which we'll discuss, and it's slowing things down. It can also happen after an inferior MI, where damaged tissue, the flow can't go through, it redirects the signal. If lead 1 is negative, or the QRS is pointing downwards, and AVF is positive, the QRS is pointing upwards, this is right axis deviation, which means the current is pulled more to the right. That can happen when the right ventricle is hypertrophied, or where there's a right bundle branch block. A pulmonary embolism is another big one. What happens here is a clot blocks the pulmonary artery, so the right ventricle has to contract against sudden pressure, and it causes a strain on the heart and a delay in conduction. Now, if both lead 1 and AVF are negative, that's an extreme axis deviation, also called northwest axis. And no, not Kanye and Kim's daughter, just northwest axis. This is rare and usually suggests something serious like ventricular rhythm, hyperkalemia, or some advanced conduction disease. So remember, we're not just reading positive or negative, we're using those QRS directions to infer the path of electrical flow, and from that, we deduce what's going on underneath. Next, let's talk about bundle branch blocks, or what happens when the highway splits and one lane is closed. Normally, after the AV node, the electrical signal travels down the bundle of His and then splits into right and left bundle branch, heading to the right and left ventricles simultaneously. If both branches work properly, the ventricles depolarize together, and then the QRS stays nice and narrow. But if one branch is blocked, what happens? The signal can't take the usual route. It has to spread through the muscle instead, and the muscle is slower than conduction fibers. That delay causes the QRS complex to widen, so it's over 0.12 seconds or 120 milliseconds, or more than 3 small boxes. So now that we understand the concept of what a bundle branch block is, let's review both types. In a right bundle branch block, the right bundle is blocked. So the left ventricle still gets activated on time, but the right ventricle has to wait. It gets the signal late through muscle fibers. On the EKG, here's what we will see. We will see a wide QRS, more than 0.12 seconds, or 3 boxes. In lead V1, we'll see an RSR pattern. This looks like 2 upward spikes or bunny ears, which I still remember from school. And this happens because as the left ventricle fires first, you have the R wave. And then because the right ventricle is late to follow, you have another little R wave coming right after. In leads 1 and V6, you'll see a wide and slurred S wave, since that late right-sided depolarization is moving away from those leads. What can cause a right bundle branch block? right ventricular hypertrophy because the heart is enlarged and things can get blocked through that enlargement. Pulmonary embolism, because a clot blocks the pulmonary artery, the right ventricle has to contract against sudden pressure and it causes a strain and delay. And degenerative conduction diseases, especially with age, can cause degeneration of conduction and a delay in the right bundle branch. Sometimes a right bundle branch block is incidental, but if there are symptoms, specifically even if there are symptoms of, let's say, a pulmonary embolism, like shortness of breath and tachycardia, or other abnormalities, it can be a clue that the right side of the heart is under stress. In the left bundle branch block, the left bundle is blocked. That means the right ventricle fires first, and the left ventricle has to wait. The signal takes the long, slow route through the muscle. What does that look like? Again, we have a wide QRS of more than 0.12 seconds, or 3 boxes. In leads 1, AVL, V5, and V6, we'll see broad, notched R waves. So they're broad, and there's a little notch, kind of like mountaintops, because the left ventricle activates late and unevenly. In leads V1, V2, we see a deep, wide S wave because the depolarization is moving away from the right side leads. What can cause a left bundle branch block? These are usually more serious, and it's prolonged hypertension, coronary artery disease, a cardiomyopathy, aortic stenosis, or even a prior myocardial infarction. And this is because the left ventricle is the main pump, so delays in the activation can signal significant underlying disease. And when we see that, we should always take a closer look at what might be going on with our patient. Even if they're not symptomatic, we should investigate. Okay, everyone, let's shift and let's talk about the ST segment. It's a small line that can tell us something huge. So on a normal EKG, the ST segment is flat. It's isoelectric, as we learned, and it sits right on the baseline between QRS and the T wave. This stretch represents a brief moment when the ventricles are completely depolarized, they've just finished contracting, and they're in a holding pattern before resetting. But when the heart muscle is starving for oxygen or actively injured, this segment starts to shift, either up or down, and that's our window into understanding what's happening at the cellular level. To make sense of it, we need to build a foundation. Let's talk about what happens to the heart muscle in stages: ischemia, injury, and infarction, and then we'll connect each one on how it shows up to the EKG. So when a coronary artery becomes narrowed or partially blocked, the heart muscle doesn't get enough oxygen. This is ischemia, and if you catch it early, it's reversible. At this stage, it's usually the inner layer of the heart wall, the subendocardium, that's affected first. That layer is farthest from blood supply and most sensitive to oxygen changes. So on the EKG, ischemia shows up as ST segment depression. This depression is usually horizontal or downsloping. It's seen in 2 or more contiguous leads. It's considered significant at 0.5 millimeters, that's half a small box, though at 1 millimeter, a full box, is more specific and easier to pick up. So ST depressions can mean subendocardial ischemia, the muscle is oxygen starved but not dead, and STEMI, which is non-ST elevation MI, a small infarction that doesn't go through the full wall, or a reciprocal change, a mirror image of ST elevation happening on the other side of the heart. So how do we know if it's just ischemia or an actual STEMI? That's where troponins come in. If troponins are elevated, it means cell death has started, and that confirms an STEMI. If troponins are normal, but the patient has symptoms and ST depression, we're likely dealing with unstable angina, which is reversible ischemia without infarction. But remember, this is very important. We have to repeat troponins. One normal result early on doesn't rule out evolving damage. So just because we have ST depressions and negative troponins doesn't mean it's unstable angina. It means that we have to repeat our troponins. Next, we get to injury. So when blood flow is severely reduced or completely blocked, heart cells begin to die. And now we're seeing transmural injury, meaning the full thickness of the heart is affected. This is where we see our ST segment elevation, because the injured cells disrupt normal repolarization and they shift the electrical current. So on EKG, ST elevation equals acute injury. And it tells us that we might be dealing with a STEMI, an ST elevation myocardial infarction. So how much elevation is considered significant on ST elevation? So in most leads, ST elevation of 1 millimeter or 0.1 millivolts or more in two contiguous leads is considered significant. In V2 and V3, which face the anterior wall, a little elevation sometimes can be normal, especially in young or athletic patients. So instead of memorizing exact thresholds, if there's more than 1.5 to 2 millimeter of ST elevation in V2 and V3, and it's new or associated with symptoms like chest pain, we take that seriously. And sometimes the ST segment doesn't just rise, it bulges. It forms a smooth, rounded shape that merges with the T waves. This is called tombstone ST elevation, and it looks just like what it sounds like a tombstone. It's broad, it's convex upward, and it's ominous. This pattern is often seen with massive anterior STEMIs, especially with LAD occlusion, and it's a sign that the heart muscle is actively dying. These are the patients who need to be rushed to the cath lab. There's no time to waste, like now, like yesterday. Okay, what happens if the blockage isn't relieved? Well, the cells start to die. Now we're in the infarction phase. This damage is permanent. Over time, infarction can lead to Q waves on EKG, especially in the leads facing the infarcted area. These Q waves are wide and deep, and they often persist long after the event. That's why sometimes we'll see a patient and we'll do a routine EKG for a physical and we'll see a Q wave and we ask the patient, "Oh, did you have a heart attack in the past?" And they'll say yes. And then you connect, this is why they're on a beta blocker and on aspirin and on a statin. And then that kind of leads into understanding your patient more just based on their EKG. But in the acute phase, what alerts us is still that ST elevation, especially if it matches a coronary artery territory and the patient has symptoms. So speaking of territories, understanding which leads correspond to which area really helps us pinpoint where the damage is happening. So let's review. If we have ST elevation in lead 2, 3, and AVF, that's our right coronary artery. Think inferior MI. If we have ST elevation in V1 through V4, that's our left anterior descending. Think anterior or septal MI. If we have ST elevation in lead 1, AVL, V5, or V6, that's our circumflex artery. Think lateral MI. The more areas involved, the larger and more dangerous the infarction. Now, let's talk about the one that hides in plain sight. The posterior wall of the heart isn't directly visible in a standard EKG. So if there's an infarct back there, it shows up like a mirror image in the front leads, especially V1 and V3. So this is what we look for and this is what we see. If we see an ST depression in V1 and V3, especially with tall R waves in the same leads, then we're suspicious of a posterior wall MI. And if you are suspicious, you can confirm it by placing posterior leads where you stick V7, V8, V9 on the back of the patient. And if you see more than 0.5 millimeter of ST elevation, that's a posterior STEMI. Okay, before we close, let's do a quick recap to tie it all together, because I know this is complex. ST segment should be flat. It's isoelectric. If it's not, something's off. ST segment depression can mean ischemia, such as unstable angina, and STEMI, or posterior wall MI. What we do is we confirm a non-STEMI with elevated troponins, and we repeat them to catch delayed rises. ST elevation means transmural injury, likely a STEMI, and we use lead location and general elevation to decide where it is. A tombstone ST elevation is a sign of massive injury. Don't miss it. Cath lab. Posterior MI is ST depression and tall R waves in leads V1 and V3, and we can confirm with posterior leads. Alrighty, this is the end of our EKG series part 2 lecture. If you're really vibing with the EKG flow and you want to keep building your interpretation skills, head over to part 3 of the EKG series and we'll cover chamber enlargement, hypertrophy, electrolyte changes, pericarditis, lots and lots more fun on EKG World. If you're looking for a deeper dive into the clinical side, like how to diagnose and manage unstable angina, that now that you've kind of learned about it, how to recognize an NSTEMI and a STEMI, you can check out the full lecture on acute coronary syndromes next. And as always, thank you for learning with me. Thank you for sticking through the ST segments. And if you liked this, leave a comment, ask a question, like, subscribe. And as always, Keep learning, stay curious, and thank you. I'll see you in the next one. Bye.